My job is mainly to speak on CAR T cell. It was mainly for targeted T cell therapy or targeted therapy in the NHL, but because I assume most of these targeted therapies will be covered in the individual talk, I thought it will be appropriate to mention about CAR T cell because that's a relatively untouched topic. So what I'll do in this journey is we'll take you through a basic about what is happening in the CAR T cell in NHL as per the educational sessions and what is known already, and what are the toxicities and comparison, and what is the one that is creating the waves now in EHA. So we know about the CAR T cell. It's a combination of an antigen binding element, which is from the B cell receptor, which is fused to a signaling domain in the T cell receptor, along with the co-stimulatory domain. The specific domain of the B cell is the targeting the surface antigen. These are the three specific CAR T cell constructs targeting CD19 antibody together, individually as a target as of CD19. They differ in terms of transmembrane domain and the co-stimulatory domain. Now, if you look at what is available for the non-Hodgkin's lymphoma, predominant use and approvals have been in diffuse large B-cell lymphomas or aggressive lymphomas. Three cells are available, all XC cells, T-cell cells, as well as lyso cells. All the three types are available. However, only XC cells and the T-cell cells are approved by FDA and EMA. Lyso cell has submitted for the approval. Quite likely it will get approved this year. All the three differ from each other, as I said, in terms of their construct. T-cell manufacturing is also different depending on which source they are taking it from. It can be primary peripheral the blood mononuclear cells in a XC cell, CD3 positive cell in T-cell cell, and 1:1 ratio of CD4 and CD8 given together in the lyso cell. So this is essential process for CAR T cell. Autologous T cells are collected. CAR gene is inserted and injected into the infused into the patient. Before the infusion, the lymphodepletion is done. The reason for lymphodepletion is predominantly to reduce the number of Tregs, which are going to otherwise suppress the CAR T cells. Coming to the large B-cell lymphoma, what we know, gold standard has been R-CHOP, which we have seen cures around 50 to 60% of the cases. This is the approximate curves that we usually see in terms of the cure rates. 60 to 65% are cured. Almost half of what are refractory or relapsing are not actually transplant eligible. And out of the transplant eligible, 30 to 40% are only going to be cured. So we end up having around 30% of the cases of diffuse large B-cell lymphoma, which are going to require a salvage therapy. And we know after second line therapy, most of them are not going to have a longer survival. So the CAR T cell trials, these are the three pivotal trials, ZOMA-1, Juliet, and Transcend trials, which were conducted. They basically were including only the high-grade lymphoma subtypes and predominantly included the post-transplant relapse cases as well. We'll just go through some of the details related to these trials to understand basically what new happened in the EHA. So ZUMA-1 trial was mainly the XC cell. As we can see from the inclusion criteria, predominantly age group median age was 58 years, had most of the refractory diseases in the advanced stage, and the 74% cases were refractory to second line or the later line of therapy. The allotransplant cases, relapses were not allowed in this study, and the patients with the CNS involvement was not included. 111 total intention to treat cases. Ultimately, 101 cases actually received the XC cells there. Lymphodepletion was done with Flu/Cy. CAR T cell dose used was 2 million cells. So if you see the overall response rate, it's alarming. I mean, in terms of 54% complete remission in this group, which we know are not going to do very well. Overall response rate was 82%. There was no major specific subgroup that was identified which was having a specific response better than the other group. So it was uniform across the risk group. This is a long-term follow-up which was published in ASH 2019, December. 39% progression-free survival at 2 years in this group, maintaining, and curve is plateauing there. Overall survival, 51% at 2 years. That mainly tells that there is a definite role of CAR T cell coming up. This was one of the first one, but long-term experience on that. Juliet was another trial that was basically the experience of TISA cell on the DLBCL, mainly included the similar model, except bridging therapy was allowed in this to reduce the load of the disease, which was not allowed in the initial Zuma trial. Now, the case inclusion criteria was roughly similar. As we see from here, this included almost 30% double-hit or triple-hit cases. Number of prior lines of therapies used was more than 4 to 6 in 71% of the cases. 55 were refractory to the last therapy. 40, almost 50% of the cases have received transplant and relapsed after that. The exclusion criteria still include the cases which have received allotransplant already or CNS involvement. Most of these trials actually excluded the low WBC or platelet as a criteria for inclusion. Again, similar response rates, 40% CR and overall survival there. Progression-free survival in those patients with CR was ongoing and overall survival was excellent. That means these CRs were stable over a period of time. Quite likely they are cured of the disease. So that's something that again established TISA cells as the CAR T cell also as a standard of line. This was the third trial, Transcend, which was done, which was mainly done on lyso-cell, which was the third type of the CAR T cell that was checked. Inclusion criteria were more liberal here. The allo and auto transplant cases, relapses were all included. Secondary CNS lymphomas were eligible. Again, these were given in different cell dose escalation. Median age was more liberal again, from 18 to 86 years to 63%. 63 was the median age. The secondary CNS lymphoma cases were very minimal. Autologous or allogenic transplant relapse cases were 33%. And 44% had never achieved any complete remission with any prior chemotherapy. This is the response rate, almost touching more than 50% in CR in these cases, which are ongoing from the last evaluation, 73% overall response rate. So it really is something which is amazing. What was the difference in this trial compared to the others was the cytokine release syndrome was relatively much lower, and that is what is interesting. If you see progression-free survival and overall survival, they are relatively better in a complete remission that we already know from the experience from the previous two studies. Now, what we're worried about these CAR T cell is the toxicity. So cytokine release syndrome and the neurological syndrome, they usually occur within first 7 days, neurological syndrome on a median duration of 13 days. And these are the ones scary because they can be life-threatening. And that is what increases the cost of these therapies quite a lot. Now, there is also a problem related to CAR T cell failure. So the failure happens because they either do not expand or they are having very limited cell span there, or there can be an antigen modulation in the target antigen leading to down modulation because of the loss of the antigens in the tumor cells. And there are toxicities. So all three are the limitations. That's why we need to keep searching for newer models. What is coming up now is to combine these with anti-PD-1 blocking antibodies. That's a unique study that is going to be there. So a lot of studies are going on. I'm going to concentrate on one Alexander that Dr. Reena Nair has already attributed in the EHA. So we'll go to EHA 25, quite informative related to CAR T cell, particularly for lymphoma. This was one of the studies that really caught the attention. This was an experience mainly related to the CAR T cell in UK. The unique thing about this was a real world database for the CAR T cell. And just to confirm whether it is really reflecting what exactly we are seeing in the trials are reflecting in the real world. The other unique thing was it was not center specific because there was a single protocol for inclusion of the cases, and this was countrywide data that was available. So the the patient's total 276 cases were included. Out of them, 183 was quite often related to the progression of the disease or mortality related to the disease before they can actually go for the therapy. Now, if you see the median age, again 57 years age, which is similar to the other trials that we have seen. Stage 3, 4 was almost 76%, bulky disease in 26%, had all the high-risk lymphomas that were included, including DLBCL, transformed lymphomas, and mediastinal large B-cell lymphomas. Of the total cohort, 40% had more than 3 treatment lines already received. 83%, however, has not been exposed to any autologous transplant or allogeneic transplant in the past. 61% were R-CHOP refractory, and 37% never responded to any therapy at all. And 75% were already progressing by the time the disease was, the CAR T cell infusion was done. The main problem that was seen there was turnaround time for CAR T cell, contrast to what has been seen in the US there. So there was a higher CAR T cell turnaround for almost 57 days compared to the shorter time that the CAR T cells are available. And that was one of the reasons for high dropout for intention to treat population. After the apheresis, the infusion of the CAR T cells, basically by the time most of the patients progressed. So they actually were given CAR T cell at a higher load of the disease. Bridging therapy was required in quite a lot of these cases, mainly because the disease was progressing, but 50% received chemotherapy and steroid, few received radiation, remaining received only steroids or radiation alone. Fortunately, cytokine release syndrome was not that high grade in majority of these cases, although majority got it. But similar way, the neurological syndrome toxicity was grade 3 plus was only in 18% compared to what was the main fear because of the high load of the disease. Of course, tocilizumab was used very liberally. Steroids were used in almost 40%. 36% required ICU. It is more in axi-cell compared to PISA-cell, but both the groups are not comparable, mainly because the study was not designed for comparison and there were more bulky disease cases in the axi-cell group. Cytopenia, which was lasting more than 100 days, was very common side effect related to CAR T cell infusion. So if you see the response rate, it is reflecting what actually we have seen in all the other trials. 30% of the total cases, 30% achieved a complete remission at 3 months, 15% as a partial remission. Of these patients, most of them retained their complete remission after the end of 6 months and continued. Best objective response rate was at 76%. Same experience was seen with PISA cells also, 25% CR, 7% PR, and these responses were sustainable at 6 months completion of therapy. This is the survival curve. If we see the overall responses, what we know from this experience is by end of 3 months, we know basically who are going to be long-term survivor from CAR T cell and who are likely to not respond or relapse early. If we see those who have been given versus intention to treat population cases who have dropped out, we very well know the curve separating earlier. So that means those patients did not last longer. So that definitely proves that yes, this therapy is beneficial in a real population data as well. So what has been conclusion that this was the intention to treat population in the real world outcome in a single large registry based data related to the entire nation, and it was a prospective study. So what actually we gain from there is CAR T turnaround time has to be shorter, then only it is going to be useful, and that's something that we need to look at because it's not available yet. Whenever it is available, if the turnaround time is more, I think it is going to create hurdles in terms of getting the similar responses. This is another study that attracted the attention. This basically was use of Lysocell as second line therapy. So this was a trial or the first study that actually looked into the use of CAR T cell in as a second line therapy straight away rather than waiting for a third or the fourth line. The intention was mainly to check whether we can improve upon the results further or not. This was for transplant ineligible cases. The design of the trial was similar. All the diffuse large B-cell lymphomas or high-grade lymphomas were taken. There was no criteria for a low blood count. That means practically all the cases were included if they were having a reasonable performance status. The age group was very liberal, 72. There was a median age varying from 53 to 85. So that was really good in terms of that age group, which were not eligible for any transplant. At that point of time, if we are looking at the response rates there, almost 30% of these cases had bulky disease. The cytokine release syndrome and neurological syndrome toxicity of grade 3 were very less, and grade 4 and 5 neurological toxicity was not seen in any of them. So that was one of the good points related to the therapy. If we see the overall response rate, 89%. So if we move it further, then the possibility is that if we use it earlier than later, then we may possibly be able to convert into a cure for majority of these cases who are otherwise not going to get cured. 56% of these cases achieved CR. That is the group possibly likely to benefit most. So to conclude, this is a first pilot study. There are more studies which are running now to use it as a second line therapy straight away in those cases with aggressive lymphoma, but this was the first where the results were shared. This results in high response rate and durable CR, acceptable safety profile. Despite the age group and the frailty, the benefit risk ratio of the Lysocell was quite good. And this basically is virtually suggesting that we should be using Lysocell as second line therapy and move it upward. The last study that I'll quote is the Alexander trial that was discussed once by Dr. Rina in the beginning. This was the unique thing about that was it was the first bicistronic CAR T cell that was used targeting CD19 and CD22, followed by anti-PD-1 in the patient with relapsed refractory DLBCL. The main problem, as we discussed in terms of the relapse or the lack of response, is basically there is a loss of CD19 antigen or PD-L1 upregulation that contributes to the exhaustion of the CAR T cells. What we were worried about is if we use a dual target, whether there is going to be more cytokine release syndrome or not in this trial. So simultaneous targeting was aimed as to mainly reduce the probability of relapse due to antigen loss, and PD-1, PD-L1 mediated CAR T cell exhaustion possibly can be prevented by adding pembrolizumab to the preconditioning regimen. So this was a CAR T cell, basically two constructs. They were two independent CARs. They were delivered together in the single retroviral vector. Humanized binders were used. This was targeting mainly CD19 and CD22. Co-stimulatory domains were different, which is OX40 and 41BB. They independently targeted these two antigens. Dose escalation cohort was seen from 50 million cells going up to 450 as a target. And eligibility criteria again included nearly similar data as inclusion criteria that we have used with the previous study. What was really heartening there is no major cytokine release syndrome that was seen with this. In fact, the neurological toxicity was very minimal in most of the patients. 29 patients were included. So this was a very initial data, but it looks encouraging. Yes, the CRs were achieved in 60% of the cases, and it was ongoing, and the complete remission was seen within 3 months of therapy in majority of these cases. So that is another good point about this therapy. Possibly we are going to see more of this particular the bicistronic T cell therapy trials in future. So what was the conclusion was the Auto 03 product, or which was the trial, it was successfully manufactured for all the patients with a tolerable safety profile, complete responses without a severe cytokine release or neurotoxicity of any grade was possible to achieve. Most important thing is 40% cases were treated outpatient. So that's another thing that we are looking at in most of these cases, that the outpatient treatment should be possible. So what we are looking at is the treatment landscape that we know already in terms of what happens to the 30% of the cases who are relapsed refractory are not going to be long-term survivors beyond 6 to 9 months. There, this therapy is going to change, even if it is not available right now in the country. What it is telling us is, for the newer therapies to come in, this is just creating a background against which model you need to confirm the response rates. The newer therapies will include CARs versus bispecifics versus newer molecules. So let's see which one wins. Thank you very much. Thank you very much, sir, for giving the opportunity and getting an opportunity to learn quite a lot from this EHA study.
Thank you, Ashish. There's one question for you. When Manipal Hospital, Bengaluru and you will be ready to do CAR T therapy? This question is from Nepal, Dr. Prem Rajashestra.
Unfortunately, we don't have the facility to do CAR T cell therapy. To my knowledge, no center in India is right now doing